All right. Welcome back to my slow but certain descent into madness. We're going to be doing the thyroid tonight. Knock out a little power hour of this. Here we go. 245 cards. Let's see how many we can get through in like 45 minutes to an hour. Oh, I hate it so much. Okay, here we go. Complications of hyperthyroidism. We have struma ovari, a blank of the ovary that contains hyperactive thyroid tissue. Tumor, teratoma. Okay. Upper right here is going to be, I'm not sure, a thyroid carcinoma. Okay, these are the nodules and neoplasms matrix. So we're working multiple matrices here. Thyroid storm triggered by some type of stressful event in a already hyperthyroid patient. Okay, that makes sense. Fibrous thyroiditis or Rydell's thyroiditis, steroids or surgery. Pretty non-specific. All right, this is kind of the main matrix of this PowerPoint. Hypo versus hyper. So we got to know what's on the left, what's on the right, and just details and stuff. So primary is an issue with the thyroid itself, right? So we have high TSH. The anterior pituitary is trying, right? It's pumping out TSH, but the problem is there's low free T4. T4 is that inactive form of thyroid hormone that is secreted from the thyroid gland. So that is why, that's basically what you look at to know, hey, is this hypothyroidism, is this hyperthyroidism? So from a primary perspective, okay, low free T4. Okay, probably a hypothyroidism here, right? Let's look at my TSH. If that's high and that's working properly, there's no issue with the pituitary. I call it like a mismatch here. That's primary hypothyroidism. What's the most common cause of that? Hashimoto's. I need to look at the specific lab findings for that, but they should match. Secondary is, hey, there's low-level thyroid secondary to something else, right? The thyroid itself is fine, but it's not being stimulated. So the TSH from that anterior pituitary, something's going on, there's an adenoma, whatever, it's not releasing that stimulating hormone, low free T4. Then we have something which we'll talk about in the complications of hypothyroidism, subclinical. So we have high TSH again, but we have normal free T4. So it's technically a hypothyroidism because it's like the thyroid should be high because we have all this TSH. So we'll talk about that in a little bit. But anyway, we're talking about secondary causes up here. So this is a pituitary issue. A pituitary adenoma would be one of those, okay? So it's inhibiting the pituitary's ability to secrete TSH. All right, so follicular thyroid cancer, this is that like middle one. So papillary is the most common. As we move to the right here, these are going to get more aggressive. So is a subtype, yeah. Hürthle cell cancer, I think, is a subtype of the already aggressive follicular thyroid cancer that is even more aggressive than that. It hurtles you. All right, myxedema. This is like each hypothyroidism has this myxedema, hyperthyroidism has this thyroid storm. I put them both in the bottom right corner, upper left corner of the, it's not even complications. I think this is just like causes, whatever, they're associations. So what's going on with the myxedema? If check your TC8, your TSH. TSH should be high here. Sure, okay. Hyperthyroidism. All right, so we have this treatment regimen. You want to hit them with Inderal first, beta blocker. It's going to stop that T4 conversion to T3 because the problem here is like mostly high T3 and T4. This PTU is, you're going to get these agranulocytes. When you're working with these like second line meds, you have that tapazole, methimazole, and then the PTU, which is what we use in the first trimester of pregnancy. You want to check for these agranulocytosis. Agranulocytes are not basophils, eosinophils, neutrophils, all the other stuff. maybe. So around the CBC. Most aggressive and highly malignant. This is aplastic thyroid something? Anaplastic. Yeah, we'll take that. All right. So when we're doing screening for thyroid cancer, we want to do an ultrasound every 6 to 12 months for 5 years. Oh, let's go. All right. Speaking of this PTU, yep, first trimester. We already talked about that. Myxedema coma, 50% mortality. Yeah, that is not, you don't want to play around with that. Hypothyroidism, right? Patients present with diarrhea and facial flushing. So pretty non-specific, but if you have that, yeah, you might have medullary thyroid cancer. Don't take a GLP-1, right? Contraindicated. Autoimmune hyperthyroidism. Yeah, so this is like the autoimmune, like classic cause of hyperthyroidism. This is going to be Graves' disease, where you get that exophthalmos and that proptosis. Upper right here, we have thyroid carcinoma. Oh, man. Hoarseness. Let's go. So when we are working up a patient with thyroid disorder, we order, yeah, TSH or TSH with flex to T4. So I think that's like N-free T3. So I think if these come back abnormal, the lab just automatically checks a T4. Okay. All right, subacute thyroiditis. So I think we were talking about subacute. Do we have lab values here? Yeah, so with this, you get this wave pattern. I think that's important. This is this dequervain thyroiditis. So presentation, look for months after. This is like postpartum. Yeah, that's going to be a big one there. So again, treatment is going to be propranolol or Inderal is the first primary treatment for hyperthyroidism, just in general. All right, so the actual anatomy of the thyroid gland. Follicular cells synthesize a storage hormone called, I don't remember the name of it, thyroglobulin. Okay, not a store. Oh, yeah, stored hormone. 5 to 8 times more common in women. Hypothyroidism is more common. I doubt the question will be that easy, but at least we know that. All right, so bottom right of hypothyroidism is going to be the myxedema coma. So that's kind of the big complication here. It leads to shock and death. Yeah, that's bad stuff. Pituitary adenoma can cause, so it's important to know that can cause both hypo and hyperthyroidism. It kind of depends what's going on with the pituitary. Is it heightening TSH? Or no, I guess, yeah, is it heightening TSH in the case of hyper, or is it lowering in hypo? Can also present as what? Subacute thyroiditis? No idea. Oh, postpartum. We'll take that. Ultrasound findings of cancer. So we're back on nodules and neoplasms. Hypoechoic, dark gray, not dark. Oh, taller than it is wide. So a nodule that is taller than it is. So skinny? Can we just like vertically narrow? Taller than it is wide. Subacute thyroiditis. Okay, back in the center here of hyperthyroidism. This is that postpartum thing. Yeah, so this is going to be a pretty specific pain in the anterior neck that radiates to the jaw. Might make you think of like MI, but made worse with coughing. That doesn't usually happen with an MI, or turning of the head, which means, yeah, oh, they have some inflammation there. All right, more cancer stuff, CT. All right, anaplastic is like you get all this radiation. It's crazy. I think you get CT chest, abdomen, pelvis every 1 to 3 months for 2 years. That's insane. All right, T4 is going to be the prohormone of the thyroid. So when we're talking about diagnosing hyperthyroidism, let's talk about the labs here for a second. Okay, so again, when I was talking about, look at your T3 and T4. If they're high, you're probably working with some type of hyperthyroidism. Now, to classify it, look at your TSH. Now, if your TSH is low, well, what does this mean? I don't know. No. That means the anterior pituitary is doing its job, right? Its inhibitor is high T3. It doesn't need to release TSH. We got plenty of T3, T4 in the body. So the problem there is with the thyroid. That's why it's primary. Okay, secondary. Again, start with the T3, T4. Is it high? We're probably working with some type of hyperthyroidism. Okay, now let's look at our TSH. If that's high also, that's what's probably causing the problem, right? So it's a pituitary issue. Ectopic, if it's from some other site, can't really tell the difference between that and primary, right? If pituitary's fine, the high T3, T4, the pituitary with TSH will be low, which is appropriate. Now, the first diagnosis here is a radioiodine uptake. Okay. This is going to be, we've seen pictures of this. This is where you look at uptake. Positive is going to be up. I keep saying the word uptake. No uptake is going to be cold, and actually most malignancies will be there. I think we'll talk about this more when we talk about Graves' disease or something. All right. Anaplastic, again, yeah, you're getting that CT every 1 to 3 months for 2 years. That's crazy. Infectious thyroiditis treatment. Staph or strep, so antibiotics. All right, middle here, follicular thyroid cancer. Again, this is that like more aggressive bucket. Treatment is, what could this be? Oh, a near total. So it's everything, we take out everything but the parathyroid. What's the difference to do that in a partial thyroidectomy? I guess that's just part of the thyroid. So that was a dumb question. Treatment near total thyroidectomy, spare the parathyroid. Yeah, it's really aggressive. It makes sense. We plus or minus lymph node dissection here, and then we're going to even hit them with radioactive iodine after that. It's like most of these we're doing that, except for medullary thyroid cancer. We're taking out the whole thing. It doesn't look like we're doing any radiation there, unless I just didn't write it down, which is possible. CT MRI, we're going to do, I don't know. Oh yeah, you want to do CT MRI brain after 3 months or every 3 months? Bottom left here of complications of hypothyroidism. Oh, this is simply just medication. So lithium and amiodarone, big ones there. You want to know this Wolff-Chaikoff block for amiodarone. Could be an easy question. Low voltage EKG for hypothyroidism. Makes sense. Everything's low there. No uptake is going to be a cold radioiodine uptake test. Intake of less than blank per day of iodine is considered dietary deficiency. It's going to be 100 micrograms. All right, this is going to be our, just simply the name medullary thyroid cancer. All right, it's kind of our third most aggressive. Subacute thyroiditis, there is blank damage of follicular cells. Direct. Lymphocytic. Okay. All right, after that radioiodine uptake, so start with the radio, then we do a thyroid scan. I don't know exactly what this is, but we're going to do this for ectopic thyroid, struma ovari, metastatic functioning thyroid cancer. Sure. All right, treatment for subacute thyroiditis. Is this steroids? Yeah, prednisone. We're going to do aspirin. I don't know why we're giving aspirin. Maybe we're using its NSAID effect. And then if they're symptomatic from hyperthyroid, treat with beta blockers, which would be propranolol, right? All right, Graves' disease, yeah, exophthalmos is going to be that real big finding there. And proptosis, that's the eyelid where you can see the whites at the top of your eye. I'm almost positive. I don't know my phone. Whatever, trust myself. MRI of the brain, I think that's every 3 months. Thyroid dysgenesis, inborn error for, I think that's T4 synthesis. Yeah, we can't even make the prohormone there. That's a shame. Treatment blank or surgery. This is for fibrous thyroiditis. Eosinophils. Is it steroids? It is steroids. We'll take that. Unilateral painful mass that is movable compressible, but it's a medical term. Something with an F, fluctuant. We'll take that. All right, methimazole, tabazole. So this is that first one that we want to avoid in the first trimester of pregnancy. We're going to check that CBC for agranulocytosis. Good. There's lymphocytic damage of follicular cells. Those are the ones that synthesize thyroglobulin, which is that storage hormone. Very good. So when we're working on a patient with thyroid disorder, TSH and free T3. So we're looking for T3 toxicity. Okay. Follow with calcitonin and CEA levels. Those are going to be, it's really important. Those are our tumor markers for medullary thyroid cancer, calcitonin and CEA. Okay, diagnosis. Let's talk about this. So primary hypothyroidism. So the issue is happening in the thyroid itself. Because we're talking about hypothyroidism, T3, T4 are going to be down. This just says low T4. I don't know why we're not talking about T3 in that case. I guess if it's low, T3 is assumed to be low. I don't know. But TSH, if this is primary, if we have a low T4, should be high TSH. Okay, this anterior pituitary is chilling. It's doing its job. It's not chilling, it's producing. All right, treatment for thyroid storm. Oh, yeah. So I have a mnemonic for this. So just be TID. I don't remember exactly what it stands for. I think the first one is beta blocker, which is probably Inderal. I think the D is dexamethasone. What could the I be? Oh, and it's really important. IV fluids are first and a cooling blanket because they have hyperpyrexia. All right, so I have beta blocker, I have dexamethasone. Just fill it in here. So, oh, thionamides. So we're going to hit them with one of those hyperthyroid medications, which we could use methimazole, but this one is preferred. Then we're going to actually hit them with some iodine. That's interesting. So, BTID. All right, we'll hit that again. Infectious thyroiditis. This is that staph or strep one. Can arise from hematogenous spread from fish or from piriform. I don't know. Isthmus, sinus. Let's go. Meds that decrease levothyroxine. We're going to hold these for 4 hours. PPIs, it spells pica. PPIs, iron, calcium, and aluminum hydroxide, which is found in antacids. Ridiculous. Upper left of complications of hypothyroidism is going to be not Graves. This is going to be Hashimoto's. So this is the most common cause of hypothyroidism. We're going to have a painless hard goiter. This is autoimmune that are destroying your thyroid gland. You don't want that. All right, still on this anaplastic. They've got a CT, they got a CT MRI. I think we're doing bone scans for this too, a PET scan. I don't think that is a bone scan. I think that's just like a nuclear tracer thing. I should probably look some of this stuff up. What card is this? Oh, active hormone T3, which is triiodothyronine. Let's go. Struma ovari, a blank of the ovary that contains a hyperactive thyroid tissue. Oh, teratoma. That was the first card, I think. So when we're working on a patient with a thyroid disorder, we order. Oh, calcitonin. Oh, no. Calcitonin is a tumor marker, but thyroglobulin, everything's a tumor marker. All right. Secondary hyperthyroidism. Think about it. What's free T3, T4? High. Okay. It's secondary, which means it's coming from the pituitary. So if the pituitary is messed up and we have high T3, T4, it should be high as well. Oh, that wasn't even what was covered, but that's correct. All right. Pica, what's the CF Pica? It's an electrolyte. Calcium. What bucket is this in? We hold this 4 hours before we take levothyroxine? Or after? If they decrease levothyroxine, I would assume we take them 4 hours after. Or you could take those, wait 4 hours, and then take the levothyroxine. All right, we'll look that up. It's a 4 hour thing. I think you want to hold those meds for 4 hours after you take levothyroxine. Let levothyroxine do its job and then do that stuff. All right, upper right of thyroid nodules is what? I don't know. Thyroid carcinoma. Oh, okay. It's just a cancer chilling up there. All right, myxedema coma. This is that excessive cold exposure. When we're talking about thyroid storm, that's hyperpyrexia. So it's so cool how these are just opposites. So instead of a cooling blanket, we're hitting them with a warmer blanket. Airway is going to be first here. I don't know that the order is, I mean, airway is always first. I don't know that the following order is what you want exactly in order. I don't even know what I'm saying. Bear hugger, We're going to hit them with pressors because they're hypotensive. Oh, they're hypo like everything. Yeah, they're hypotensive. Pressors make sense there. We're going to hit them with some sugar because they're hypoglycemic. Again, they're low in everything. IV fluid replacement and then stress dose. Steroids? Hydrocortisone. Okay. Labs, check TSH. What's it going to be in myxedema coma? Is this primary or secondary? I think it's just going to be high. I think I just have to memorize that. All right, prednisone and aspirin for subacute thyroiditis. Bottom right, myxedema, bear hugger blanket, and what's that first med? Pressors. Good. Middle right is just something thyroiditis. Infectious thyroiditis. Okay. Staph, strep, piriform sinus, I think is the big buzzword there. All right. Bottom middle. What is this? I don't know. Just subclinical hypothyroidism. Okay. Toxic multinodular goiter. This is called Plummer's disease. The treatment of this is going to be, I don't know, antithyroid medication. Okay. Pick your dealer's choice, I guess, on that. All right. This is back to thyroid nodules. This is going to be the papillary one, which is the most common. Okay. I forgot to cover up that other one. Triggers for myxedema coma, some type of stressful event, right? In an otherwise hypothyroid patient, CHF pneumonia, cold exposure, I think is the big one there. Maybe they'll be hypothermic. That's why we're warming them up. Subacute thyroiditis. This is where we see that wave pattern with the labs, deep queer veins. Treatment. Goal is to simply replenish thyroid. So we kind of talked about the treatment for hyperthyroidism. Hypothyroidism is just one medicine, right? It's levothyroxine, it's Synthroid. It's a synthetic T4. So we're giving them the pro hormone. I think that's important. Brand necessary sometimes is important here. We're going to start low because it takes time to regulate levels. We're going to recheck in 6 weeks. They want to take this on an empty stomach and take it in the morning. Okay, thyroid stimulating hormone. Yes, stimulating is going to be low T3 with inhibitor, meaning high T3. Subacute thyroiditis result is a release of free T3. Oh, stored T3, T4. That's important. This is that postpartum one that releases stored T3, T4. So it's not increasing production. Meds that decrease levothyroxine. This is PICA. So this is aluminum hydroxide found in like Tums. So that's going to inhibit levothyroxine. We want to hold that for 4 hours. Look for months after childbirth or 2 weeks after. Oh, yeah, you can get a viral infection for this too with subacute thyroiditis. Presentation, fatigue, weight gain. Oh, a review of systems question. Cold intolerance. All right, toxic adenoma, upper right. Oh, and the other one was wasn't there a carcinoma in the other one? Adenomas that secrete T3, T4 and gradually suppress, probably TSH. Yeah, well, this is the cancer one. Thyroid carcinoma. Middle one is going to be the HERTH thing. Isn't it follicular? Yes, follicular thyroid cancer is in the middle. Yeah, because you fall over the hurdles, like hurdles in track. You hurt yourself. So Hürthle cell cancer and follicular go together. Hopefully that's a question. Follow serum thyroglobulin, a tumor marker, and a blank every 3 to 6 months. CEA? Oh, TSH. But I think that's just in general. So confusing. Inhibited by excessive iodine and lithium. So lithium is going to inhibit TSH. That's why it's going to cause hypothyroidism. It would probably technically be a secondary hypothyroidism, right? Based on our diagnosis labs. Weight loss without appetite loss. I think the idea with that is just like your body's just in overdrive. So you have tachypnea. Yeah, you're breathing off your weight, basically. Your metabolism's going crazy. Slow reflexes with hypo. Taller than it is wide. So a nice skinny thyroid nodule is going to be suggestive of cancer, and greater than 1 centimeter. That's huge. And microcalcifications. Weight loss without appetite loss. Yes, remember that for hyperthyroidism. Blank myxedema. Oh, this is the Puta orange. I don't know. Pre-tibial. Okay. So on your legs. After pressors, we do what? Glucose? Let's go, baby. All right, bottom left, fibrous thyroiditis. This is that Riedell's thyroiditis, neck discomfort, dysphagia, probably hoarseness here too. I mean, how are you supposed to know the difference between all this? From some other site, ectopic, TSH should be fine, should be low, T3, T4 should be high. The thyroid is above the suprasternal notch, just below the cricoid cartilage. All right, so we talked about propranolol, Inderol. We talked about our thionamides, that methimazole, which we avoid in the first trimester, propylthiouracil, the PTU, which we can give in the first trimester, but we check our CBC. We also check LFTs for that PTU. And then we can also use radioactive iodine, just not if they're pregnant. Also, if they have significant exophthalmos, you want to avoid that too. All right, what's the storage hormone here? Thyroglobulin in the follicular cells. Dosing is variable and measured in micrograms. Dosing is so sensitive brand necessary, maybe best. Causes for subacute thyroiditis, viral infections. This is why we were talking about post-viral infection. C cells, calcitonin, regulate calcium and phosphorus. All right, antithyroid medication, methimazole, then hit them with, this is for toxic multinodular goiter or Plummer's disease. Then we can hit them with radiation. Follicular cells, that's it. This is the primary cells of the thyroid. Okay, okay. Bottom right here, this is of hyperthyroidism. Think about this for a second. It's not myxedema coma, it's simply thyroid storm. All right, papillary thyroid cancer, pretty good prognosis. Yeah, like I said, these get worse as we move to the right there. I got some viewers there. 88 pages. Thought I was going to break 100 for this one. Ooh, what did we just say? I don't know. All right, middle left. What is this? It's a hyperthyroidism. I don't know. Oh, it's Plummer's disease. Okay. Yeah, we just have to remember that that's there. Pre-tibial, no, not pre-tibial edema. Myxedema is going to be non-pitting edema. That's pretty big for hypothyroidism. Radioactive iodine, don't do that to pregnant women. Makes sense. For levothyroxine, start low because it's going to take time. Inderol is going to stop T4 to T3. Infectious thyroiditis, common offenders. All right, so we can kind of make this connection here. We got viral over here. We kind of got bacterial over here. Staph and strep there. That's in that piriform sinus. Prednisone, aspirin, and then if symptomatic with what's in the middle here, this is de Quervain's. Oh, what's it called? Is it just subacute thyroiditis? Yeah. So this is going to be beta blockers. What's to the left? Is it Plummer's disease? Let's go. Okay. I need to remember Plummer's is hyperthyroidism. I don't know. You're taking a plunger and just hyperly plunging something. Upper right here is it's just thyroid adenoma. Toxic adenoma. Hypothyroidism. What are their hands going to look like? Their hands, puffy? Subacute thyroiditis, also called what? De Quervain's. It's the thumb guy. Follicular cells, primary cells, has what receptors? TSH. Yeah, that's big because of reasons. TSH receptors. TSH comes and binds to the follicular cells. All right, so that's why we get goiters with hyperthyroidism. Hashimoto's thyroiditis, autoimmune hypothyroidism, 7 times more common in women. Most common cause of hypothyroidism, good. Hashimoto's on the left, Graves' disease on the right. CBC, you're going to get anemia with hypothyroidism. Makes sense. Everything's like low. 90% have Mets to lungs for anaplastic. Yeah, most aggressive, very malignant. Not good. What's your BP finding on? Yeah, definitely think this is going to be a vignette, a wide pulse pressure. So you'd have a blood pressure of like 140 over like 60 or something. It's probably a little extreme, but something like that. Total thyroidectomy if possible. And then this external beam radiation. I didn't see that anywhere else other than this anaplastic. Most common cause of hypothyroidism is going to be Hashimoto's, the autoimmune one, right? Patients present with what and facial flushing? Isn't it diarrhea? Let's go. All right. Middle complication of hyperthyroidism. What is this? A goiter without associated hyperthyroidism. I don't know. Just non-toxic. Okay, all right. So we have non-toxic goiter here, and then we have the word toxic here, but then we also have the word toxic here. But this is a toxic adenoma. Okay. Medications causing hypothyroidism, lithium and amiodarone, where we get that Wolff-Chaikoff block. I don't know that we need to know anything else. Oh, I thought this is an EKG finding. It's not. The iodine influx blocks the formation of more T4. That's important. Okay. There is blank damage of follicular cells, lymphocytic in subacute thyroiditis, right in the middle. Medications causing hypothyroidism, we just talked about that, amiodarone. So I don't know, vignette, maybe look for somebody with like AFib who's like on that for like rhythm control or chemical cardioversion. Okay. Thyroid storm, number one support with IV fluids. Makes sense. They're going to be real sick. Follow a serum what? A tumor marker. This is the storage hormone, isn't it? Thyroglobulin. Yeah, but for what? I think just thyroid cancer in general. Calcitonin and CEA, though, I think are the more specific ones for medullary. So same labs as the toxic adenoma, which is going to be what? A decrease in TSH, but with an increase in T4 and T3. I can get behind that. All right, thyroid storm treatment. All right, so BTID, so beta blockers. T is thionamides. This is those second line medications for hyperthyroidism. I think the one we want to use here is the PTU one, which I should probably know what that's called. I is iodine and D is dexamethasone. Let's go, baby. All right. Severe clinical manifestation of hyperthyroidism triggered by some type of stressful event, surgery, illness, trauma. So somebody who already has hyperthyroidism, we're stressing them out. We are going to see a TSH decrease here, okay, with free T4, T3 increased. So despite this crazy storm, TSH is like, bro, you got enough T4, T3. I'm chilling. All right, so when we're working on a patient with thyroid disorder, we order thyroglobulin. Yes. All right, steroids or just surgery for this Riedell's thyroiditis. I don't know much about that one. Cold, no uptake. Most malignancies have a cold radioiodine uptake. Diagnosis, primary hyperthyroidism. Start with T3, T4, high, done. All right, it's primary. That's where the problem is. If that's high, TSH should be low. AKC cells that produce calcitonin, which regulate blank and phosphorus levels. Calcium brings down calcium, increases phosphorus. Classic Hashimoto's. No pain, right? Just a painless goiter. Yeah. Ah, yeah. Okay. Thyroid storm, hyperpyrexia. Yeah, it's like 104 to 106. That's crazy. So that's probably going to be the vignette. And then it's going to be like, number one treatment's going to be fluid, but then it's going to be, I don't know. You gave them a beta blocker. What do you give them next? Oh, this is going to suck. Thyroid storm. Levels of T3 and T4 What? Oh, do not correlate with the severity of disease, just like amylase and lipase don't correlate with a pancreatitis. TSH suppression for everything but medullary. Okay. THS, TSH. Oh, we don't want to do any TSH suppression except for with, I'm sorry, we do want to do TSH suppression, but not with medullary thyroid cancer. Okay. Oh, this is huge. Hypothyroidism, your cholesterol is up. So you have high total cholesterol and high, I would assume, LDL. Infectious thyroiditis from the piriform sinus. Thyroid nodules more common in women 2 to 1, but cancer is more common in men. I think that's important. Pituitary adenoma can cause hypo or hyperthyroidism. Developmental delay and blank growth and development, stunted, delayed, impaired. Subclinical hypothyroidism patient is asymptomatic? All right, what is a stimulator? Oh, good question. Stimulator of thyroid releasing hormone. I think this is serotonin, actually. Gee, sure. Follicular thyroid cancer, blank cell. Oh, Hearth, health, Hearthfuls, Hearthfuls. I don't know how to say the U with the umlaut on it. Follicular cells are going to be primary, are like supporting cells, are para something. Parafollicular. All right, we'll take that. Contras, I just remember the emoji, honestly. Radioiodine uptake contras are pregnancy? Okay. You're not doing like any of this if they're pregnant. You don't do the radioiodine uptake and you don't do radioactive iodine. Really nothing with radio in it. PTU, agranulocytosis, we're going to look out for that also. So when we're working on a patient for thyroid disorder, free so TSH with reflex to free T4. More common than hyper. High TSH and normal. Oh, this is that subclinical. Yeah, we were talking about high TSH, but normal, probably T4 here. You ultrasound every 6 to 12 months for how many years for thyroid cancer? That doesn't really matter. 5. Upper right here is going to be what? Radiation to head and neck, family history of thyroid cancer. Is this just thyroid carcinoma? Yes. Don't do TSH suppression for medullary thyroid cancer. This blank is the largest single organ, the thyroid. Blank for everything but medullary TSH suppression. Follicular cells. Result is a release of, oh, stored for subacute thyroiditis. That is really important. All right. Propylthiouracil agranulocytosis also follow LFTs, use PTU. So we can use that propylthiouracil in the first trimester. You can use it. Good. P for pregnant. Hürthle cell cancer is a subtype that is even more aggressive than follicular thyroid, which is already more aggressive compared to papillary. Bottom left is going to be anaplastic thyroid cancer. Real bad. It's going to met to the lungs. You need an insane amount of radiology, monthly CAT scans, basically. All right, subclinical hypothyroidism, good. This is just a matrix of 6. So it's good, so I won't get it confused with the hypothyroidism one. Myxedema coma, shock and death. Subacute thyroiditis, look for months after childbirth or after viral infection. All right, we're learning. Treatment is hyperthyroidism going to be your propranolol, stops that T4 to T3. Pituitary adenoma can cause hyper and hypo. Middle of hypothyroidism, right after Hashimoto's, between congenital. This is like iatrogenic hypothyroidism? Yeah, that's exactly right. All right, toxic multinodular goiter plumber's disease. How we treating this guy? Why is it so long? I wonder if I could just reason through this. Is it not just a medicine for hyperthyroidism? Is it not just, oh, I think that's exactly what it is. It says anti-thyroid hormone or anti-thyroid medication, and then in parentheses, I put um, methimazole. Oh gosh. All right. Myxedema coma, 50% mortality. Graves' disease is going to have what type of myxedema? Pre-tibial, the pulle d'orange, raised red thickened feet, legs. I think it's raised red thickened like rash growth on the feet and legs, not your feet and legs themselves. Medullary thyroid cancer, patient present with diarrhea and facial flushing. Thyroid carcinoma, you're going to have some cough, dysphagia, hoarseness. We're also going to get that with something that was in the bottom left. I guess a lot of this you can kind of get that. No, yeah, Rydell's had some dysphagia and hoarseness. Upper left of hyperthyroidism is Graves. We still have 104 new cards we have to see, so we're not out of the woods yet with this. This is myxedema coma, but we are sending cards to tomorrow, which is good. T4, the pro hormone. What's it called though? Thyrine? Thyroxine. What is thyrine? Amino acid? Causes can also present as blank thyroiditis. Postpartum? Again, that's for subacute thyroiditis. That's our center of our hyperthyroidism. Radioiodine uptake. Yeah. It's our diagnostic tool. It's the first thing we do. It's an oral tracer. Then we image after 8 to 24 hours. Positive is increased uptake. And we see where are where's the uptake? Where's the nodules, whatever. I should probably look at those pictures. I'm sure there's going to be pictures on this. Follow a serum, thyroglobulin, and TSH for your thyroid cancers. Struma ovari. What's TSH? I think TSH is high here. If no, it's not. It's decreased. Okay. Medullary thyroid cancer, we're going to follow this one with a calcitonin and a CEA. Thyroid nodules, it's going to be taller than it is wide. Bottom left here for complications of hypothyroidism, simply just medications. Papillary thyroid cancer is going to be the most common and has a good prognosis. Popular. Progressive weakness, stupor, and reduction in what? Myxedema coma. I had no idea. Oh, every vital sign. We'll take that. All right, upper right. What is this called? I don't know what this is called. Congenital hypothyroidism. Look for pain in the anterior neck that radiates to the jaw. What is this even for? Subacute thyroiditis? Yeah, good. Made worse with coughing or turning the head. Again, subacute thyroiditis. Treatment. Do you remember the treatment for those? Prednisone, steroid. That is a steroid. Prednisone, aspirin, and beta blocker to treat the symptoms. We'll check that in a second. We're going to do a near total thyroidectomy for what's in the middle here, which is the HERTH, so follicular, so everything but parathyroid. CT MRI of the brain for anaplastic. You are getting a CT of almost your entire body every 1 to 3 months for 2 years. All right, if you have secondary hyperthyroidism, start with your T3, T4. Got to be high, right? Secondary, so it's not a problem with our thyroid, which means what? Which means it's a problem with the pituitary, which means it's going to act inappropriately, which means it's going to be high. Oh, good. This is what I just said. So prednisone, aspirin, beta blockers for subacute thyroiditis. All right. I think I like subacute thyroiditis. Radioiodine uptake. Look at where and how much. What am I saying here? Oh, if it's cold. This is called a Wolf something block. What is this again? This is it's the prevention of T4 to T3, right? No, it's actually just it's the formation of T4 itself. So it's the Wolf-Chaikoff block. I'm going to do that one again so I actually know what it is. Thyroid scan is this thing we do after the radioiodine uptake. We're looking for ectopic thyroid, struma ovarian. We're looking for things. Thyroid cancer treatment and follow-up for anaplastic specifically, like CT. Treatment for infectious thyroiditis. This one's going to be staph and strep, so antibiotics. All right, it's 8:24. A few more minutes here, and we'll call it a night. Upper right is going to be non-toxic goiter. Oh, toxic adenoma. Let's go. All right. Middle right here is, oh, not papillary, medullary thyroid cancer. All right, this is pica, so it's going to be iron, something we want to hold for 4 hours. After, toxic adenoma, how we treating this guy? All right, it's surgery, take it out. Radioactive iodine. Hashimoto's thyroiditis, autoimmune hypothyroidism, radioiodine uptake, treatment for fibrous thyroiditis, Riedell's, steroids. What is this? I don't know. Oh, come on, it's plumber's disease. Yeah, your whole lipid panel is increased. Not technically, your cholesterol synthesis. What's the most common cause of hyperthyroidism? Graves' disease. Please be a question. Just please. Low voltage EKG. Free T3 with TSH with reflex to T4. Oh, just C cells? Parafollicular cells are called C cells. These are the ones that cause calcitonin. They tone down calcium by putting it back into the bone, right? And then phosphorus. All right, so primary for hypothyroidism, again, the problem with the thyroid. So your T3, T4, or I think they just say T4 in this case, is low, which means anterior pituitary is fine, and that's going to be high. Intake of less than blank micrograms a day. Intake of less than blank micrograms a day of iodine, 100. Check CBC for agranulocytosis. Unilateral painful neck mass that is fasciculation, something with an F, fluctuant, whatever. For infectious thyroiditis. Okay. Complications of hyperthyroidism. All right, what is this? A goiter without associated hyperthyroidism. Is this just a non-toxic goiter? Yeah. Okay. Exophthalmos or proptosis. Yeah, we're gonna get. I'm not memorizing all 6 classes of this no specs thing. I'm taking the L on that. I'm just gonna do like the extremes. Meds that decrease levothyroxine hold for 4 hours. There's lymphocytic damage of what cells in subacute thyroiditis? Follicular. For anaplastic specifically, blank brain after 3 months, MRI, CT. Thyroid dysgenesis, inborn error for what synthesis? T4 probably. Upper left, thyroid nodules, neoplasms. It's just the word thyroid nodules, right? Yeah. Taller than they are wide. For levothyroxine, start low. It takes time to levels recheck 6 weeks after? Yeah. Check blank for CBC. Can arise from a hematogenous, I can't say things, from the piriform sinus. And this is infectious thyroiditis. Staph and strep live here. Antibiotics. and this is the fluctuant. Complications of hypothyroidism, upper left. This is just your Hashimoto's. Follow with calcitonin and CEA for medullary thyroid cancer. Bottom middle, a teratoma. Wide pulse pressure, new onset AFib for hyperthyroidism. Yeah, that's interesting, right? The active hormone is triiodothyronine. Iodine deficiency or excess can cause hypothyroidism. Okay. Thyroid scan for ectopic thyroid, struma arvari, we want to do that for too, which is that teratoma. Thyroid storm, tachycardia, CV collapse, hypotension, and shock. We're going to get that hyperpyrexia. Ultrasound findings suggestive of cancer greater than 1 centimeter. We're going to have microcalcifications. Yes, you don't want that. That is suggestive of cancer. Inhibitors of thyroid releasing hormone other than elevated T3. This is going to be dopamine. So Sera up, dopes down. What kind of weakness for hyperthyroidism? Proximal, so your thighs and like shoulders. I don't think it's shoulders, but I think thighs is the big one there. Medullary thyroid cancer, cancer of what types of cells, aka C cells? So parafollicular. Will lose lateral third of your eyebrows in hypothyroidism. Treatment for medullary thyroid cancer is partial, total. I think total. Medullary is, you're not messing around there. No radiation, I don't think here. Meds that decrease levothyroxine, hold for 4 hours. Pica, what's the C? Yeah, that's calcium. Dosing is variable and measured in what? Micrograms, MCG. I don't know why that's important. Triggers a blank event, a stressful event, myxedema coma. That's what's going to put you in thyroid storm too. Thyroid is the largest single organ. The role here is to excrete mostly T4 and to a lesser extent T3. Yeah, so it does excrete some T3, I think 20%, but 80% of the T3 is coming from T4. That's an iodine is yeeted off of it. All right, secondary. This is just going to be a pituitary. A PET scan every 3 to 6 months for what? Anaplastic thyroid cancer. Look for pain in the anterior neck that radiates to the jaw for what? Subacute thyroiditis, of course. All right, middle right here is infectious thyroiditis. Tachycardia to CV collapse. Yeah, CV storm is like no big deal. The problem is I have to make sure I don't confuse my bottom right for thyroid storm with myxedema. But I think if I think through it, I should be fine. Graves' disease, autoimmune hyperthyroidism. Presentation, look for months after travel, 2 weeks after viral infection. Yeah, I mean, this is a 3x2. Treatment, manage airway. You get the bear hugger out, then you hit them with some pressors because all their vitals are going to be low. Screen all newborns at birth for congenital hypothyroidism. All right. I am going to call this here and make sure I get a good night's sleep tonight. We actually broke a new record today. That's 2 personal bests, 2 days in a row. I hit 1,400 cards. I hit 983 unique cards today. Spring semester is ridiculous. All right, so my goal tomorrow morning is to finish thyroid. I've really not touched 6 or 7 or not good. All right, catch you in the next one.